Hello, my name is Erica Gano, and I'm here today to discuss the psychiatric mental health nurse practitioner's role in the practice setting of geriatrics. Psychiatric mental health nurse practitioners are prepared to take a lifespan approach. We will care for our population from birth until death. Mental health disorders are thought to affect 25% of our elderly population. Psychiatric mental health nurse practitioners are expected to differentiate medical diagnoses from that of mental health disorders. Collaboration is crucial to the care for this population in a holistic approach. When we discuss collaboration, we want to consider the patient's families and/or caregivers. We want to collaborate with their primary care providers. We want to collaborate with that gerontologic nurse practitioner who may be providing care to the patient. We would like to always collaborate with the pharmacist to discuss medication reconciliation. Long-term care facilities and/or rehab facilities, and also with palliative care and/or hospice care in that end-of-life spectrum. Psychopharmacology requires us to consider the aging population's medical comorbidities and possible drug interactions or side effects. Polypharmacy is an issue that we always need to keep in the front of our minds when we're initially assessing these patients, and then also at each follow-up appointment, we want to complete medication reconciliations to ensure the safety of this population, especially when we're discussing that collaborative approach. We do have to remember that primary care may be, adjusting medications, other specialists. So it is very important to look at the board of pharmacy, but also maybe spot check with the pharmacist. If something just doesn't seem accurate, to double check, take that extra time and double check with the pharmacist to ensure that that all of the medicines that are being prescribed are safe and an effective treatment plan is there in play. We want to assess these patients, initial assessment, if not close follow-up with them, and we can use multiple screening tools. These tools may include the Geriatric Depression Screening Scale. We want to look at cognition and memory. We may use the MoCA, the MiniCog, the SPMSQ, the Folstein MMSE, and/or the CDT. We also want to look at functional assessment and safety assessments. Keep in mind, with this population, risk of falls, risk of abuse, and then once again, polypharmacy. So we need to look at all of that for the safety of the patient. We want to look at dementia rating scales, staging scales, or tools, because if we can determine the stage, that will help us to determine the intervention that's appropriate. 4 common tools that rate and stage dementia are the functional assessment test, the FAST test. This is something that if you only have a certain amount of time with a patient at that specific appointment, it's a 7-stage scale based on function. And then the mini mental scale. Clinical dementia rating, 6 domains, which include the memory, orientation, judgment, problem solving, community affairs, home and hobbies, and personal care are assessed with this. And then there is the Blessed Dementia Rating Scale, which is a 22-item scale that assesses behavior and instrumental and physical activity of daily living. One good way to remember these are the amount of questions or the amount of information that's provided. That may help you decide which scale is appropriate for that visit as far as time frame that you have allotted for the patient. When delirium or acute onset of change in LOC is noted, we really need to look at differential diagnoses prior to just saying a cognitive impairment. We need to look at organic causes, dehydration. Does the patient have a urinary tract infection? Are they exhibiting symptoms of a stroke? Have they had a fall? Is a brain injury possible? Then we also need to look at lab results. Is their renal function stable? Is their blood sugar extremely high? Are they malnourished? Is their liver function abnormal? Is their thyroid function normal, abnormal? And then also, as far as medication, so, monitoring, making sure that primary care is monitoring that TSH level for the patient. Is infection, I mentioned urinary tract infection, but also, what is their sedimentation rate? What's their white cell count? You need to look at that within the blood work. You also may need to look at cardiac status. Does that patient have a history of coronary heart disease or myocardial infarction, congestive heart failure, things like that? And of course, looking at electrolytes, looking at the sodium, looking at the glucose, potassium, calcium, magnesium. And then also maybe, we don't want to think that our elderly population is abusing substances, but completing a drug and alcohol screen is very important as well. We don't ever want to assume. Also, cognitive impairment may be neurocognitive. This would include, imaging to be completed, which would be vascular disease, Lewy body disease, frontotemporal lobar degeneration. And that may be, something that obviously we send towards neurology and or vascular. Also, we want to consider, is the elderly patient depressed? Are they having sleeping disorders? Is there a substance abuse or polypharmacy issue? Causes of depression may include Parkinson's disease, stroke, cognitive decline, uncontrolled diabetes, obesity, isolation, and or decreased mobility. Insomnia needs to be considered as far as a reason for change in mental status. The sleep cycle needs to be thought of with these patients as a blood pressure of mental health. Changes may be related to an underlying disorder, and that needs to be considered. Anxiety is the #1 mental health diagnosis in this population. Anxiety is found to be related to somatic symptoms, which means if a patient has a continual complaint of either a pain or some sort of problem that is not found with testing, so it's not found in labs, it's not found in imaging, but yet the patient continues to complain of this specific issue, then it may be secondary to an uncontrolled anxiety. When we're trying to treat anxiety with this population, we do want to try antidepressants. And remember, with this population, we want to always start low and go slow with the titration. We also want to look at cognitive, sensory, or physical impairments that may be related to causing the anxiety of the patients. And also, and this is something that I wasn't truly aware of, but new onset panic attacks are very rare, and it may be secondary to a side effect to a medication that you're prescribing, so keep that in mind as well. Also, when we talk about anxiety, it does specifically state multiple times throughout the text that uncontrolled anxiety also leads to depression with this population, which makes sense, and that goes along with isolation and immobility, things like that. Elder abuse needs to be considered as well when you're assessing the patient. You have to consider the entire dynamic of where that patient is living and who is taking care of them. You have to think of the situation of both the caregiver and the patient, and also the daily strain of conflicting needs of both of those parties. Communication and collaboration of expected needs may improve the circumstance. So when you discuss, home life and do these assessments, you want to speak to the patient and, if possible, the caregiver as well, and truly ask questions of safety, ask questions of just overall being cared for, but get both views when you're asking those questions. Ethical dilemmas that may need to be considered, ensuring informed consent and confidentiality, determining decision-making capacity, promoting advanced care planning, advanced directives, and also the patient's wishes, for instance, like a DNR documentation. These are all topics that need to be discussed with both the patient and the caregiver or medical power of attorney. So that needs to be completed also within that first assessment. It is the holistic approach that a psychiatric mental health nurse practitioner utilizes to integrate the vast and ever-growing needs of our aging population. Collaboration is at the center of geriatric care. Thank you all and have a great day.